Hi, my name is Dr. Ellen Storm, and today is the 21st of February 2026, and I'm going to be talking about the first of the Lucy Letby cases, the case of baby 1, or otherwise known as baby A. I'd like to start with a disclaimer. What follows is based entirely on my own appraisal of the information currently available in the public domain. I do not have any special access to information, and I have not had access to the medical notes. What follows is entirely my own appraisal of the situation and does not represent the opinion of any other person or organisation with which I may be associated. I have never worked at the Countess of Chester Hospital or with any of the persons involved in this case. I have no personal connections with any of the patients or professionals referenced here or in relation to the case of Lucy Letby more generally. What I offer here, I offer sincerely in the spirit of contribution and in the hope that truth and justice may prevail.
I would like to begin by extending my sincerest condolences to the family of baby 1 and to all the families affected by this situation. I am so sorry both for your loss and for everything you have been through subsequently. I hope the truth will bring some peace to you in the end. To give a bit of background to what I'm about to say, Lucy Letby was convicted of the murder of baby 1 by the intentional administration of air into the circulation, causing air embolism on 18th August 2023. In total, Lucy Letby was convicted of 7 murders and 7 attempted murders of babies on the neonatal unit at the Countess of Chester Hospital between June 2015 and June 2016. She was sentenced to life imprisonment with a whole life order on the 21st of August 2023. What I'm about to say. Baby 1 may have died from natural causes, including as a result of being the premature male twin of a mother with antiphospholipid syndrome. Baby 1 may have died from iatrogenic causes, including thromboembolic stroke or pericardial effusion, cardiac tamponade. Air may have entered the circulation of baby 1 during resuscitation via one of 2 central lines if a cap was left off or a 3-way tap was left open. Air may have formed in or entered the circulation of baby 1 during resuscitation due to the rupturing of pulmonary vessels or the pneumatization of dissolved gas during CPR. After death, air may have formed as a result of putrefaction. Taken together, these points give cause for reasonable doubt in relation to the safety of Lucy Letby's conviction in this case. What I would like to happen now. The original work involved in compiling this presentation took me 1 full week of my own annual leave time. It was entirely voluntary. I sent the contents of this presentation, differently formatted, to Mark MacDonald on the 1st of April 2025. This was my 5th email to him, and I have never received a reply. I sent the contents of this presentation, differently formatted, to Lord Sumption on the 3rd of April 2025, and received a reply from his clerk saying that he had read it with interest, but was not able to offer any advice. I would like to receive confirmation that the CCRC has been provided with and fully understands the implications of the contents of this presentation. I would like to be able to give my attention to the other babies in this case, but I have significant time limitations due to my own work and family commitments. I would be grateful for any or all assistance in this matter. Thank you. About me. I qualified with an MBBS in 2000 from St George's Hospital Medical School in London. I started my paediatric training in 2002 and gained my MRCPCH membership of the Royal College of Paediatrics and Child Health in 2004. I have worked in over 30 different hospitals in England and Wales. I have worked in 4 Level 3 and 2 Level 2 neonatal units. I have worked in a specialist child protection unit where I wrote over 40 court reports and attended court as a witness on one occasion. I now work as a specialty or SAS doctor in paediatrics and neonates. I am not a neonatologist or a consultant paediatrician, but I do have a BSc in biomedical sciences, an MSc in public health, and an MA in creative writing. And I am the author of the book Diseases Have Causes, One Doctor's Journey with an Apple and a Pen, which is concerned with the philosophy and sociology of science, particularly in the field of human nutrition. I'm particularly fascinated in the question, how do we know what we know? My book is concerned with this in relation to nutrition, but it is in some ways equally relevant to our subject today. In my book, Diseases Have Causes, One Doctor's Journey with an Apple and a Pen, Book 2, I discuss the work of 20th century philosopher Ludwig Wittgenstein, who had a particular interest in the ways in which language relates to and represents truth. Wittgenstein is famous for a very small book called the Tractatus Logico-Philosophicus, in which he describes this relationship in a series of logical propositions, short numbered statements, each of which corresponds to a single thought. Although Wittgenstein later adapted his ideas on the way that language works more generally, the Tractatus remains relevant to our purposes here, because it describes a particular kind of formal logical thought. This presentation is both about the facts of this case specifically and also a demonstration of a more general method for getting at the truth in situations of considerable scientific and medical complexity. It is important to note that there are many details about this case that have been withheld from the educated and professional public, see outstanding questions below, that prevent definitive conclusions from being drawn. In this way, we can never be 100% certain, and we are held in a position of ignorance that demands our continued faith and trust in the judicial system. However, both truth and the prevention of miscarriages of justice in an age of rapidly escalating scientific complexity require openness, transparency, and accountability, and this means full disclosure of relevant information by both the healthcare and legal professions. That said, what follows is a series of logical propositions based on the information I have available to me at the present moment in time. Those propositions follow the and, however, therefore format, and each proposition constitutes a single unit of thought, while together they constitute a thought process and make that process explicit. They are the linguistic equivalent of the mathematical relationship A plus B minus C equals D. They allow an interrogation of the facts and the relationships between them. They allow the most logically accurate conclusions to be derived. They should be viewed as a continual work in progress, always subject to change as new information emerges. Each should be accompanied by a statement of origin, i.e. a reference. Timeline of events. On the 7th of June 2015 at 20:31, babies 1 and 2, twins, are born by caesarean section at 31 plus 2 weeks gestation. On the 8th of June 2015 at 1600 hours, baby 1's peripheral cannular tissues and a UVC is inserted. At 1900 hours, baby 1 has a peripheral long line inserted, and at 2000 hours, fluids are infused through this long line. At 2058, the death of baby 1 is confirmed. I might add here that this is a very sketchy timeline. This is all the information I have been able to gather about exactly what happened to baby 1 and when during his short life. The questions to be addressed. Does any evidence exist supporting the proposition that baby 1 died from natural causes? Does any evidence exist supporting the proposition that baby 1 died from iatrogenic causes? Does any evidence exist supporting the proposition that baby 1 died from air embolism? Does any evidence exist supporting the proposition that individual medical error may have contributed to the death of baby 1? Does any evidence exist supporting the proposition that systemic organisational failures may have contributed to the death of baby 1? My investigation of the facts. Baby 1 was born premature at 31 weeks and 2 days gestation, 8 weeks and 5 days before his due date. And gestational age is a clinical variable presenting an increased risk for mortality that is adjusted for in the calculation of adjusted standardized mortality ratios. And the neonatal mortality rate per 1,000 births for infants born between 28 plus 0 and 31 plus 6 weeks gestation in the UK in 2015 was 34.14. And the neonatal mortality rate per 1,000 births for infants born at term between 37 plus 0 and 41 plus 6 weeks gestation in the UK in 2015 was 0.74. Therefore, baby 1's risk of dying during the neonatal period by virtue of his gestational age was 34.14 divided by 0.74, which equals 46.14 times higher than that of a baby born at term. The birth weight of baby 1 was 1,660 grams. And birth weight is a clinical variable presenting an increased risk for mortality that is adjusted for in the calculation of adjusted standardized mortality ratios. And the neonatal mortality rate per 1,000 births for infants born at birth weights between 1,500 grams and 2,499 grams in the UK in 2015 was 6.56. And the neonatal mortality rate per 1,000 births for infants born at birth weights between 3,500 grams and 4,499 grams in the UK in 2015 was 0.41. Therefore, baby 1's risk of dying during the neonatal period by virtue of his birth weight was 6.56 divided by 0.41, which equals 16 times higher than that of a normally grown baby. However, the birth weight of baby 1 was on the 50th centile average for gestational age. he did not present with intrauterine growth retardation. Therefore, it would not be expected that the birth weight of baby 1 would increase his risk of neonatal mortality over and above the increased risk already attributable to gestational age. Baby 1 was a male infant, and sex is a clinical variable presenting an increased risk for mortality that is adjusted for in the calculation of adjusted standardized mortality ratios. And it is well recognized that male infants are more at risk of a variety of adverse perinatal outcomes, as demonstrated in one 14-year retrospective cohort study of 130,133 births, which showed overall higher rates of neonatal mortality, 0.12% versus 0.06%, p-value less than 0.001, and severe neonatal morbidity, 12% versus 9.1%, p-value less than 0.001. And the neonatal mortality rate per 1,000 births for male infants in the UK in 2015 was 2.05. And the neonatal mortality rate per 1,000 births for female infants in the UK in 2015 was 1.46. Therefore, baby 1's risk of dying during the neonatal period by virtue of his male sex was between 1.4, 2.05 divided by 1.46, and 2, 0.12 divided by 0.06 times higher than that of a female baby. Baby 1 was a twin, and multiple pregnancy is a clinical variable presenting an increased risk for mortality that is adjusted for in the calculation of adjusted standardized mortality ratios. And the neonatal mortality rate per 1,000 births for twins in the UK in 2015 was 5.26. And the neonatal mortality rate per 1,000 births for singleton infants in the UK in 2015 was 1.64. Therefore, baby 1's risk of dying during the neonatal period by virtue of being a twin was 5.26 divided by 1.64, which equals 3.2 times higher than that of a singleton baby. The mother of baby 1 suffered from antiphospholipid syndrome. And antiphospholipid syndrome is an autoimmune condition in which damage to the endothelial cells lining blood vessels is caused by antiphospholipid antibodies, resulting in the formation of blood clots or thromboses. And around 30% of babies born to mothers with antiphospholipid syndrome also have these autoantibodies, which cross the placenta before birth. And, although rare, blood clots or thromboses associated with raised levels of antiphospholipid antibodies during the neonatal period have been described. Therefore, it is plausible that baby 1 was predisposed to thrombotic events due to maternal antiphospholipid syndrome and transplacental transfer of antiphospholipid antibodies. Baby 1 was found to have a non-occluding blood clot or thrombus in the liver on post-mortem. And baby 1 had an umbilical venous catheter, or UVC, inserted, which was subsequently replaced for malposition. And a common site for the malposition of UVCs is the liver, because the catheter diverts from its intended course into the portal venous system. And thrombosis is a recognized complication of UVC placement. Therefore, it is plausible that the thrombus in the liver formed around the tip of the malpositioned UVC, such that once the catheter was withdrawn, it left a non-occluding central channel. Baby 1 had an umbilical venous catheter and a long line in situ on his post-mortem X-ray. And central venous catheters are associated with a number of complications, including infections, extravasation, and the less common but potentially fatal cardiac tamponade. Therefore, central venous catheters should be removed as soon as possible if they are malpositioned, not working, or no longer required, or if there is concern regarding the possibility of a serious catheter-related complication. Baby 1 collapsed shortly after fluids were commenced via the long line at 2000 hours. And the British Association of Perinatal Medicine Framework for Practice on the Use of Central Venous Catheters in Neonates states that if a baby with a central venous catheter in situ deteriorates, the possibility of catheter-related complications should be considered, including extravasation and tamponade. And during his resuscitation, baby 1 became bradycardic, i.e. he developed a slow heart rate, and small ECG complexes were noted. And small ECG complexes are a recognized feature of massive pericardial effusion. And while tachycardia is also a feature of pericardial effusion, bradycardia in the context of shock, where oxygen delivery to the heart muscle has become insufficient, is considered a pre-terminal sign. And autopsy findings for 5 neonates who died suddenly and unexpectedly, despite aggressive resuscitative efforts, as a result of pericardial effusion or cardiac tamponade, caused by the infusion of total parenteral nutrition into the pericardial cavity via central venous catheters, have been described. And the tips of the catheters were found within the right atrium in 4 cases, but proximal to the right atrium in 1 case. And despite recommendations made in 2001-2002 that catheter tips should be placed outside the right atrium, and that the movement of neonates with central venous catheters in place should be restricted to prevent catheter migration, cases of PCE-CT have continued to be reported. And in patients with upper limb lines, changes in the position of the arm have been postulated to cause migration of the tip. And cases with appropriate CVC tip positioning have been reported, but no post-mortem examinations were carried out in any of these cases. And there are specific actions that pathologists should take at autopsy in cases of suspected PCE-CT. And 3 mechanisms have been identified for the development of PCE-CT: direct myocardial damage and microperforation of the myocardium by the catheter tip, and interstitial edema and dilated fine vascular channels caused by permeation of hyperosmolar infusion fluid through the right atrial wall with the catheter tip either inside or outside of the right atrium. And PCE-CT should be considered in all cases of neonates with sudden cardiac decompensation. It should be diagnosed by diagnostic imaging and treated with pericardiocentesis or needle aspiration. And chest X-ray may show an enlarged cardiac shadow in subacute cases, but bedside functional echocardiography has been described as a means of both diagnosing PCE-CT and guiding needle pericardiocentesis in cases of acute deterioration. Therefore, the explanation that baby 1 collapsed as a result of a complication of central venous catheter placement, specifically PCE-CT, is in keeping with the clinical information available to date. And functional echocardiography plus minus pericardiocentesis was not carried out for baby 1. and it is not reported that the long line was removed or that alternative circulatory access was obtained. And 7 doses of adrenaline, each of which would have been followed by a saline flush, were given during the resuscitation of baby 1. Therefore, if 1. The 7 doses of adrenaline and 7 saline flushes were given via the long line during resuscitation, and 2. PCECT was present, then further deterioration due to impaired cardiac filling in diastole would have been the natural and likely result of these 2 conditions, due to that fluid volume being delivered to the pericardial cavity. Baby 1 had skin discoloration at the time of his collapse, and the skin discoloration was variously described as very white with sort of purpley blotches and very cyanotic by the shift leader, purple-blue with red and white patches by Dr. Harkness, and very pale to blue with unusual pink patches mainly on the torso which would flit around by Dr. Jayaram. And white skin in shock is due to peripheral vasoconstriction and poor perfusion, reduced blood flow to the skin. And purple-blue skin, cyanosis, is due to hypoxia and the presence of deoxygenated blood in the circulation. It can occur as a result of any pathology that impairs gas exchange in the lungs or impairs the circulation of blood from the lungs to the rest of the body. And red skin or erythema can be due to either local or general systemic, as in septic shock, inflammation or infection, resulting in hyperemia, increased perfusion due to vasodilation, or bleeding into the skin due to clotting disorders or disseminated intravascular coagulation. Therefore, the reported colour changes are very non-specific and could have multiple explanations. And all dying babies become first blue, then eventually white, whatever the cause, as the circulation shuts down. And nobody drew any diagrams of the unusual discolorations in the medical notes. And nobody took any medical photographs of the unusual discolorations, either during the resuscitation or immediately after the death. And Dr. Jayaram did not document anything about the skin discoloration in the medical notes at the time. And Dr. Jayaram conducted a literature search and found the Lee and Tanswell paper in June 2016 after a consultant meeting at which the possibility of air embolism was suggested as an explanation for the multiple events that had occurred. Therefore, it might be reasonably concluded that the skin discoloration of baby 1 was not felt to be out of the ordinary for a dying baby in whom resuscitative efforts were failing at the time. And that given that the description of flitting was applied retrospectively a whole year later in response to the suggestion of a team member, it may have been subject to recall bias. Baby 1 had a line of gas in front of his spine on his post-mortem X-ray, and it was stated that this demonstrated gas in one of the large vessels of the body, and it was not stated which large vessel this was anatomically likely to be, and the level of this gas in relation to the thoracic or lumbar vertebrae or the diaphragm was not stated, and it was not explained why the gas might not be in the esophagus, which anatomically passes in front of the spine and immediately adjacent to the descending aorta. And no lateral X-ray image was referred to which might have assisted in making this distinction. And no post-mortem CT scan was referred to, which might have assisted in clarifying the presence of air in the vascular system. Therefore, it is not possible from the information given to the public to conclude that the gas was definitively intravascular and not intraesophageal. And it was stated that the imaging is not diagnostic of how the gas was introduced.
And one case has been reported in the literature of air embolus that resulted from a central venous catheter becoming disconnected, such that air entered the circulation without the application of positive pressure. And 2 cases have been reported in the literature of air emboli resulting from disconnection of subclavian venous catheters. Both of these cases were noted to be mildly dehydrated. And in 2018, the Faculty of Intensive Care Medicine and the Intensive Care Society issued a safety alert after the coroner determined that the cause of death of a postoperative adult patient was air embolism after it was noted during CPR that the 3-way tap of the trauma line was open to air.
And the recommendations of the coroner to prevent future deaths from air embolism associated with central lines was for units caring for patients with CVCs to ensure that any unused taps attached to CVCs are closed to air and capped off with an appropriate device, and that units should consider how this action is recorded, and that any lumens not in use should be clamped closed. And it is not stated whether the UVC that was left in place during the resuscitation of baby 1 was a single or double lumen UVC. And the Joint Standards Committee of the Faculty of Intensive Care Medicine and the Intensive Care Society was in 2018 developing national guidelines on the detection, referral and treatment of air embolism. In the meantime, they recommended that hospital trusts and health boards should ensure that they have appropriate systems in place to prevent harm from incidences of air entrainment through CVCs. And no comment has been made about how the UVC was closed or what measures were taken to verify that it was adequately closed at all times. And in relation to air embolism in dialysis patients, it has been noted that in the face of a favourable air-to-blood pressure gradient and an abnormal communication between the atmosphere and the veins, air entrance into the circulation is common. And a greater pressure gradient results from dehydration and hypovolemia due to reduced central venous pressure. Both of these are risk factors for air embolism that should be corrected during catheter placement. And during CPR, negative intrathoracic pressure is generated between chest compressions, allowing chest wall recoil and facilitating venous filling of the heart. This effectively sucks blood into the chest. Therefore, if the gas was intravascular, it may have entered the circulation before or during resuscitation due to an accidentally unclamped UVC lumen or a 3-way tap that was accidentally left open to the air. And cardiovascular gas has been demonstrated on non-traumatic post-mortem CT scans in 71%, 163, of 228 patients who underwent CPR, and none of 19 patients who didn't. And, in addition to air inflow via venous catheters, cardiac massage is thought to cause pneumatization, the formation of bubbles of dissolved gas in the blood by a process known as tribonucleation. Therefore, if the gas was intravascular, it may have formed during the prolonged period of resuscitation, including CPR, to which baby 1 was subjected as a result of pneumatization. Baby 1 had an air bubble found at post-mortem histology of the brain and lungs. And it is not stated whether this bubble was in the brain or the lungs. and the size of this bubble is not specified. And intracerebral air embolism has been demonstrated on CT scan and reported in the literature in 4 adult cases following cardiopulmonary resuscitation, or CPR. And 3 of these cases had either coexisting pneumocephalus or pneumothorax, but 1 case had neither. And this is described as being the result of entrance of air into the circulatory system via ruptured pulmonary vessels during cardiopulmonary resuscitation. Therefore, there is precedent in the literature for, and a mechanism to explain, the proposition that the bubble seen on postmortem histology was generated during CPR. My opinion. Does any evidence exist supporting the proposition that baby 1 died from natural causes? Answer: yes. Baby 1 was a premature male twin. Being premature, being male, and being a twin are all risk factors associated with higher rates of neonatal mortality. Answer: yes. Baby 1 was the infant of a mother with antiphospholipid syndrome and may have received transplacental antiphospholipid antibodies which predispose to thrombosis or blood clot formation. Does any evidence exist supporting the proposition that baby 1 died from iatrogenic causes? Answer: yes. Baby 1 was found to have a non-occluding thrombus or blood clot in his liver on post-mortem, which may have formed around a malpositioned UVC. And it is theoretically possible that a bit of this thrombus could have broken off, forming an embolism, travelled via the inferior vena cava to the right atrium, crossed the foramen ovale to the left atrium, and from there travelled via the arterial system to the brainstem, causing a thromboembolic stroke, as suggested by the international expert panel. However, this diagnosis is speculative and without evidence of occurrence. There is a more likely explanation for the collapse of baby 1, for which there is both evidence in this case and precedent being well recognised in the literature. Answer: yes. Baby 1 collapsed shortly after fluid infusion was commenced via a newly inserted long line or central venous catheter. The temporal relationship is in keeping with this having caused his collapse. And central venous catheter placement is associated with a number of well-recognised complications, including pericardial effusion, PCE, which results in cardiac tamponade, CT, which results in sudden collapse and death if unrecognised and untreated. And PCE-CT is associated with low voltage, small ECG complexes, as were noted in the case of baby 1 during his resuscitation. Does any evidence exist supporting the proposition that baby 1 died from air embolism? Answer: yes. Air was identified on post-mortem X-ray, which was considered to be in a major blood vessel. And an air bubble was found at post-mortem on either the brain or lungs. However, it does not automatically follow that because air was found post-mortem, that the air was the cause of the death rather than the consequence of either that death or the resuscitation attempts that immediately preceded it. And association is not the same as causation. To establish air as the cause of the collapse rather than the result of it, it would need to be established that the presence of air temporarily preceded the collapse, which it is not possible to do. And there are at least 6 possible explanations for the observed line of air, other than deliberate administration with intent to cause harm, as follows. 1. The line of air was in fact in the esophagus or gastrointestinal tract. 2. The line of air was the result of putrefaction. 3. The line of air was due to a cap being left off one of the central lines, or a three-way tap being left in the open position during the resuscitation. 4. The line of air was due to accidental infiltration of air by a member of the resuscitation team while giving fluid and adrenaline boluses. 5. The line of air was due to the rupturing of pulmonary vessels during a prolonged period of CPR. 6. The line of air was due to pneumatization of dissolved gas during a prolonged period of CPR. Does any evidence exist supporting the proposition that medical error contributed to the death of baby 1? Answer: yes. The fact that there were 2 central venous catheters in situ at post-mortem indicates that a. The UVC was not removed at the first available opportunity once the long line had been placed and determined to be in a correct position. b. The possibility of a serious catheter-related complication, specifically cardiac tamponade, was not considered during the resuscitation and therefore was potentially not identified or treated. Answer: yes. In addition to the above, several other things that should have been done in this case have not been described and still need to be verified. See outstanding questions below. Does any evidence exist supporting the proposition that systemic organisational failures may have contributed to the death of baby 1? Answer: yes. It has not been stated that the hospital trust had ensured that they had appropriate systems in place to prevent harm from incidences of air entrainment through CVCs on the NICU. Answer: yes. It has not been stated that a root cause analysis after the event in relation to the likelihood of a CVC-related complication was carried out, suggesting a lack of awareness of the risk associated with CVCs. Outstanding questions. Please note, the answers to these questions are required for a full understanding of the case and to be able to draw correct conclusions. Did the mother of baby 1 receive antenatal steroids, and if so, when, in relation to the time of birth? Did the mother of baby 1 have HELLP syndrome, hemolysis, elevated liver enzymes and low platelets? What was the extent of the resuscitation required by baby 1 at birth? What were baby 1's cord gases? Did they suggest intrapartum hypoxia? What were baby 1's initial and subsequent gases? Did they show either respiratory or metabolic acidosis at any point? What were baby 1's blood results prior to his collapse? Did he have a clotting screen sent? Did baby 1 have blood sent for antiphospholipid antibodies or a thrombophilia screen either before or after death? When exactly were the 2 central lines inserted? When was the UVC reinserted? Where was the long line inserted? Into which limb? And if it was in his left leg, did it cross the midline on the X-ray? i.e., can we exclude lumbar vein malposition? What were the positions of the tips of the UVC and long line on X-ray? Did any of the X-rays show deviation of the UVC tip into the liver? Did any of the X-rays show a central line tip within the cardiac shadow? How many X-rays were taken to position the lines? How many times were the lines repositioned? Was heparinized saline infused while waiting for the X-rays? What was the exact temporal relationship between the insertion of the long line, the reinfusion of fluids, and the collapse? Why was the UVC still in situ at post-mortem? Was a root cause analysis carried out after the event to consider the possibility that the death was related to either of the 2 central lines? Was pericardial effusion which causes small ECG complexes, causing cardiac tamponade, considered as a possible cause of the collapse of baby 1? Could or did the post-mortem exclude pericardial effusion or tamponade? Specifically, did the autopsy report comment on the position of the lines and or on the state of the pericardium and myocardium? Were any photographs taken or diagrams drawn at the time to record the skin discolorations? Were any contemporaneous notes made in the medical record regarding unusual skin discolorations? Who first highlighted concerns that the discolorations were unusual, and when? How old was baby 1 in hours at the time that he collapsed? What respiratory support was baby 1 receiving at the time of collapse? How much oxygen was he receiving? Was he intubated and ventilated? And if so, when? What did baby 1's chest X-ray show? Did it show signs of respiratory disease, such as respiratory distress syndrome? Did baby 1 receive surfactant at any point? What did baby 1's observation chart show in the hours leading up to his collapse? Were his observations absolutely stable, or did they show signs of progressive deterioration? What were baby 1's blood sugars during the period when he was not receiving any fluids? Why was baby 1 resuscitated for 30 minutes? Was discontinuation of resuscitation discussed amongst the team before this point, given the extremely poor neurological prognosis? During the resuscitation, were the fluids stopped? Was the line withdrawn? Were the 7 doses of adrenaline given via the long line? Did anyone ask for or attempt an echocardiogram? Did anyone consider or attempt pericardiocentesis? Did anyone consider or attempt intraosseous access as an alternative route for fluid administration? Final thoughts. Prematurity itself is a cause of death. 100 years ago, every 31 plus 2 week gestation baby died. In developing countries today, most 31 plus 2 week gestation babies still die. Now, most, but still not all, 31 plus 2 week gestation babies survive in the UK. They survive because we have neonatal units and paediatric and neonatal doctors who have dedicated their lives to learning how to keep them alive. They survive because we have equipment and techniques that allow the delivery of fluids and nutrition before they are developmentally able to feed. The application of those techniques requires skills that must be learnt and carries risks, but without them there is no chance of survival at all. We cannot create a situation in which good doctors and nurses are villainised when things go wrong, because then very soon we will have no doctors and nurses and no service at all, and then every premature baby will die. Good practice. The family of baby 1 should have been counselled prior to his delivery in relation to the elevated risk of mortality posed by his gestation, his sex, his being a twin, and the maternal antiphospholipid syndrome. The family of baby 1 should have been counselled about the potential risks and benefits of line insertion in advance, and asked for their consent. After baby 1 died, his family should have been counselled about the possible natural and iatrogenic causes for his collapse, and any uncertainty around the reason for this should have been communicated. Statutory duty of candour should have been applied in relation to any iatrogenic harm that may have occurred. The team should have received a full debrief in relation to the events to facilitate the development of a no-blame learning culture that demonstrates active compassion towards health professionals who have made mistakes. because the natural psychological defense mechanism of good people who have made a mistake that has caused harm is denial, associated with the projection of blame onto other people or systems. But doctors who have made mistakes do have to develop insight and learn so they don't make the same mistakes again. This process can be difficult and painful. This is what good practice looks like, and it is regrettable that it does not appear to have been applied here. Conclusion. We may never know for certain why baby 1 died. There were multiple naturally occurring factors contributing to his increased risk of death. There were temporally concordant iatrogenic factors that may have directly caused his death from either thromboembolic stroke or PCECT. There may have been opportunities to intervene or to take different actions that may have prevented his death. There are multiple natural and or iatrogenic explanations for air in the circulatory system after death, especially after prolonged CPR. In the absence of any direct and unequivocal evidence of maleficence, natural or iatrogenic causes are much more likely and provide grounds for reasonable doubt in this case. I've provided a list of references here which you can access if you download the original PowerPoint presentation. Please see the link below. Thank you.